Thanks for coming. This is our second Finish Well presentation, so thank you again for being here. Oh, louder, closer, there we go. This topic today is on hospice, so I hope that's what you were expecting. You will find on your table a list of each hospice that serves the Green Valley area, as well as the questions from the American Hospice Association that you can use to interview or search out a hospice that you might want. After our session is over, we have brochures from the various hospices in the back that you can pick up. And God has provided a really good team for this ministry, and I just want to recognize them, and I'm sorry, I'm kind of, emotional. I do that when I speak in front of people. I have the gift of tears, so bear with me. So May Moss, Ted DeZurich, Shirley Gray, Marie Bells, who's not here, and Karen Long. And I want you to please to feel, we all have these weirdo looking name tags. So please feel free to speak to any of us if you have questions, comments, whatever. But today I want to call out Karen. She has worked long and hard to get all these brochures and this list made up, and I'm just so thankful. So thank you, Karen. Our speaker today is Jose Montejano.
Yep.
Jose Montejano. He's a hospice care coordinator, and I know you're going to like this presentation. He's just going to do a great job. So thank you, Jose.
Thank you.
The Finish Well ministry is under the umbrella of Pastor Ron Jacobson, and he's going to begin our session with prayer today. Pastor Ron.
Good morning. Well, thank you. Thank you. Good morning. I'm so honored to be here, and I want to thank Sylvia and the Finishing Well team for inviting me to be here with you today. And I'd like to start by reading a portion of God's Word for you this morning. And I discovered it in a tiny little book in the Old Testament. And I bet you, I would be surprised if some of us have never read it before. It's the book of Nahum. And it's found in chapter 1, verse 7. And God's Word says this: "The Lord is good. He's a strong refuge when trouble comes. And He is close to those who trust Him." So let's pray. Our good friend Jesus, we thank you for giving us this peace that passes all understanding, since we are discussing a topic which is or will be, to some of us here today, very important. Just the word hospice is such a powerful word, as you know. But when we see your face shining down upon us, you remind us of your peace, your love, your strength, your faithfulness, your constant companionship. So in this day, in this moment, I pray that all of us here today would just fix our eyes on you. For as long as we gaze upon you, Lord, the safer we feel, and the circumstances around us don't seem so large. Thank you, Lord, that you are an unchanging God. And we rejoice this morning that you are always beside us, and with eagerness we look forward to learning and hearing more about hospice. Because hospice is just one of the many gifts that you have given us as our life on earth draws to an end. But we do rejoice that the resurrection of Jesus assures us of a bright future. Father, we just thank you that you are here with us today. I pray that you'll just fill our hearts with joy and peace and an eagerness to learn and interact. We thank you for our guest speaker and for all those who are here today. We ask this in your sheltering name. Amen.
Amen. Thank you.
Hello? Oh, okay. Looks like it's working. Hi, everybody. My name is Jose Montejano. I am the hospice care consultant for Gentiva Hospice. Today, we are just going to be speaking about what hospice is in general and giving you examples of our team that we have, all the services that is a benefit that everybody does receive, whether they have Medicare, Medicaid, VA insurance, or private insurance. All right.
When you say PEMA, is that for the county, or?
What was that?
When you say PEMA, is that the county that you represent?
So yes, so we represent Pima County, Santa Cruz County, and that's for Gentiva Hospice. Other hospices might cover Cochise County, just depending on what they're certified for. All right, we're just going to explain a little bit of the objectives that we're going to go over. So we're going to explain the hospice care philosophy. We're going to discuss the goals of hospice care, identify qualifications for hospice care eligibility, discuss covered services under the hospice benefit, and then also state hospice care payer sources. And I just want to make sure everybody can hear me okay.
I would like it a little louder.
A little louder?
Else like it a little louder?
Okay.
Probably be a good idea to silence our phones too.
Yep. You go. Okay. Let me see if I move it. How is that? Is that better? Okay. Okay. Starting out with the hospice philosophy. Care that focuses on providing palliative care to patients with life-limiting illness, focusing on palliative patients' pain and other symptoms, attending to their and their family or loved ones' emotional and spiritual needs, and providing support to caregivers. Sorry about that, we're having some technical difficulties. Okay, there we go. So what is hospice? Hospice is considered the model for quality, compassionate care for people facing a life-limiting illness. We provide expert medical care, pain management, and emotional and spiritual support expressly tailored to the patients and their families' needs and wishes. We focus on comfort care and quality of life rather than curative care. The goals of hospice are self-determined life closure, natural death, comfortable and peaceful dying experience, effective grieving. Now, there is some common misconceptions when it comes to hospice. Some of them is a patient must be in the final stages of dying in order to be eligible for hospice care. That is not necessarily the case. A lot of times, the patients that we bring on a hospice, we hear from family, friends, the patient themselves, is that they wish they had started hospice sooner. You do not have to be in those final stages where it's a week before the patient passes where they're starting hospice. We like to start hospice services before that. Once you have a prognosis of 6 months or less, that is when we like to start hospice services, is when the patient themselves are having that decline where they are not able to maybe get dressed as fast in the morning. Maybe before it was taking them 20 minutes, now it's taking them an hour and a half. They're not able to cook for themselves, clean for themselves. They're having multiple falls. Things like that is what we look for in order to make a patient eligible for hospice. That way we can have that pain and symptom management earlier so that patient does not happen to get into that crisis where they're in that end of life stage. Another one is hospice care is just for the elderly or cancer patients. Also, that is not the case. Sadly, we do have patients that are far younger and as well as children also. So there is no age limit on where hospice is appropriate. And then also the Medicare benefit only covers 6 months of care. This one is a big one where a lot of people think hospice care is only going to be for the 6 months due to the 6 months prognosis. That is not the case. We have had patients that have been on for several years where they're on multiple what we call benefit periods. So the benefit period is 2 benefit period of 90 days followed by an unlimited amount of 60-day periods. After each benefit period, a nurse practitioner will come out, reevaluate, reassess the patient, and recertify them for continuance to hospice. And what that is they're showing that the patient is declining, meaning that they qualify for hospice. Some of the times we do have patients where we do start them early, where they're having that pain and symptom, where we manage that, and after the first or second 90-day period, or even after a 60-day period, we call what's called graduating, where they have actually, since they are receiving that in-home care of the pain and symptom management, they actually do get better to where they might want to continue chemo, continue radiation, things like that. So they graduate off hospice services, restart maybe some treatment, and say a year down the road, they have that decline again. We are able to recertify them for hospice and start services again. It doesn't mean that if you graduate hospice, you cannot come back. That is not the case. And then also, if a patient elects hospice services, they can no longer see their primary physician.
Would you
Yes.
repeat those timelines again?
The benefit period?
Yes, please.
Okay, so when you first start out on hospice, you are in your first benefit period. So with that, there is 2 90-day benefit periods followed by an unlimited amount of 60-day benefit periods. So after the first initial benefit period of 90 days, nurse practitioner will come out and do what's called a face-to-face, and they will reassess the patient to ensure that they still qualify for hospice. And then there is the second 90-day period. Again, the nurse practitioner will come out to do that face-to-face, and then you have an unlimited amount of 60-day periods where our nurse practitioner, again, comes out and does that face-to-face. Okay. Mhm. If a patient elects hospice services, they can no longer see their primary physician. This is one of the biggest ones that we see where patients do not want to start hospice services because they feel like they would lose their primary care physician. A lot of patients have that really big trust in their primary care physician as they've been seeing them for a very long time. If someone does choose to elect hospice services, they are able to keep their primary care physician. All we would do is ask their primary care physician if they would like to follow. If they agree to, they can be the point of contact where any medication changes, any symptom management, things like that, that we need to change, we would reach out to your PCP at that time, receive that order, get those medication changes, and everything like that. Yes, go ahead.
I'm just wondering, how often is it that primary care physicians would agree to stay on versus decide not to, ratio-wise? Do you have any idea?
I don't have an exact number ratio-wise, but I've been doing this a little over.
Question, please, because I couldn't hear it.
Oh, yes.
Thank you.
So she asked is, what is the ratio of physicians that actually do follow patients that are on hospice services? And I don't have the exact number, but like I said, I've been doing hospice for a little over 5 years now. I would say 8 times out of 10, the physicians are willing to follow and keep their patients. Mhm. Okay, and then these are the Medicare hospice qualifications. Certification from attending physician and/or hospice medical director that a patient has a terminal illness with a life expectancy of 6 months or less. Patient and/or patient representative elects palliative care, comfort care, rather than curative care. Signed election statement choosing hospice care versus other Medicare-covered treatments for terminal illnesses and related conditions. So when we talk about the attending physician or the medical director with a terminal illness of 6 months or less, if a patient were to choose to elect hospice services and would like an evaluation done, and say their PCP maybe isn't on board with hospice, sometimes we do get that. The patient has the choice to elect hospice services. That is a patient right to them. So we have our own medical director as well, to where if the patient's primary care provider is not wanting to, per se, sign an order for hospice saying that maybe the patient, they don't feel in their eyes qualifies for hospice, but family and the patient themselves feel they do need that help, that is something where we can have our medical director get us that order, send a nurse out to do that evaluation to see if the patient does qualify for hospice and start services at that time. So just because sometimes there's some physicians out there that are kind of against hospice does not mean that you guys are not able to receive the services that you need. Right here, this is just a graph showing the top hospice diagnoses, what we admit patients under. The majority would be Alzheimer's, dementia. Secondary would have cardiovascular heart disease, along with cancer, respiratory diseases, strokes, kidney disease, and severe malnutrition. And with the added new one that we started seeing back in 2020, which is now COVID. Right here is the Medicare hospice utilization. This is the number of Medicare hospice users. So as we see from year 2016 to 2020, we have had an increase in people utilizing hospice. Before, a lot of people did not really understand what hospice was in general. After doing educations like this, we know that everybody now has a better understanding of hospice and uses that benefit. And then right here is just the U.S. hospice market projections, same as last, where we can see that increase of people utilizing that hospice benefit. So right here, it's what does hospice cover? So right here, we're going to go over what hospice covers, and we have the 4 levels of hospice care, and then access to entire hospice team, the medications, medical equipment and supplies, and additional therapy services as needed. So the 4 levels of care are routine hospice care, which is in-home hospice care, whether that be a private residence, an assisted living, or long-term care at a skilled nursing facility. Then we have continuous home care, general inpatient care, and inpatient respite care. So we'll go over a little bit about those. So routine home care, that is care provided wherever the patients call home. Most common level of hospice care consists of regularly scheduled care visits. Then we have continuous home care, which is provided to allow patients to remain at home during a period of crisis when pain or symptom management requires frequent adjustments to medications and or treatments. Short-term level of care that is reevaluated every 24 hours.
Jose,
Yes.
could you tell them about when they go home, they can be on hospice here and on hospice there?
Yeah, definitely. So she asked if I can explain a little bit more about if patients are on service per se here in Green Valley and were to move out of state.
Or go back home?
Or go back home.
Snowbirds.
Yep, since we do have a lot of snowbirds here in Green Valley, a lot of the times where patients are not only from here, but from another state as well, where they travel back and forth, you can get onto hospice services here in Green Valley. I'll just go over with Gentiva here. We have multiple offices across the United States. So say someone were to here and then want to travel back home to the East Coast, all we would do is transfer services from here to where their home is, and they can start services at the office in their home. And as well, if it's a place where the hospice agency does not have an office per se, what they would do is find a hospice agency within their hometown, send them over all the information needed so that way, once they get there, they can be established with that new hospice while they're there. And then vice versa. If they wanted to come back in the wintertime, then they can be transferred back to the same hospice. You're welcome.
And just to clarify, that transfer is handled by each hospice company, not the individual?
Yes, so what you asked is that is covered by the hospice agency, not the individual? Correct. So that would be the hospices that are in charge of that. So from one hospice, they would send the information to the other hospice. They would have that all situated. Most of the time, you want to have that a week before the patient is actually traveling back home. That way, there's nothing falls through the cracks. They make sure that they have all the information. So that way, as soon as they do get there, they have a nurse waiting for them to admit there.
Nice.
Regarding the continuous care, that was a little fuzzy to me. What does that actually include?
Okay, you asked what does the continuous care do?
Yeah.
Okay, so for continuous care, this is when we have patients that are at home and they're having pain and symptoms. So say increased nausea and vomiting, uncontrollable pain. So what that is we'll send a nurse out to do daily visits. And that's reassessed every 24 hours to make sure that the patient's pain and symptoms are under control. And that'll be on a daily basis until those symptoms are resolved. Okay. I think I went one too far. Okay, so the next one is general inpatient care. This utilizes for crisis care when pain and symptom management cannot be managed in other settings. Provided in a hospice inpatient facility, hospital, or Medicare certified nursing facility where 24-hour nursing staff is unavailable. And then there is inpatient respite care, short-term inpatient care provided strictly for caregiver relief, Utilized when a patient's family is a primary source of care and cannot meet their loved one's needs due to caregiver stress or other extenuating circumstances. Any questions on maybe general inpatient care or respite care? Yes.
Respite care requires that you meet all of those qualifications, the Medicare qualifications for hospice care in order to be qualified for inpatient respite care?
Yes, so you asked, sorry, I gotta read for the video. You asked respite care has to meet all the qualifications for hospice? Yes. So yes, you would have to meet all the qualifications for hospice. Once admitted onto hospice services, this is an added benefit. So what we use respite care for is for caregiver burnout. We know the majority of the times, the one caring the most for their loved one is that caregiver, is that family member, the wife, the son, the daughter, the aunt. So with that, we know it is a big task in order to care for somebody when they're in their end of life. So what we do is, which is the respite care, it gives 5 days where we transfer the patient from their home into a facility so that way they receive the care that they need and give the caregiver a break. Mhm.
How frequently can you, or how often can that be, can they get respite?
Okay, and you asked how often can you get respite? So it's a maximum allowed days of 5 days, and that restarts every month, I believe.
Every month?
Every month?
Yeah, that you have that benefit. Any other questions?
That's
Provided in hospice patient, 24-hour care, is that like a full nursing home where Medicare pays for it?
Sorry, can you restate the question? I could not hear you.
Provided service for 24 hours, should the patient need it. And like, for example, there is no caregiver. There is a hospital where they can go and Medicare pays for that.
Okay, so you asked for the 24-hour care. If the hospice provides that 24-hour care
Yes.
for the general, so for general inpatient, in order to get that 24-hour care, that is a facility that either the hospice is contracted with, or there is only one hospice in the Tucson area, that is Casa de la Luz, that has their own inpatient hospice care beds. So with that, we are contracted with facilities, say skilled nursing facilities, hospitals, where we have those inpatient beds, where we would transfer the patient from their home to that facility to where they can get that 24-hour nursing care.
And would that go on potentially for the 6 months?
So that would not necessarily go on for the potential of the 6 months. With that is usually for the pain and symptom management. Once those symptoms and that pain is resolved, we would transfer back home. And that's assessed on a daily basis as well.
Thank you. So, a point of clarity, because I think Pepe House
Mhm.
at Tucson Medical Center has inpatient facility, correct?
Yes.
Okay. I also believe that there's a stipulation that it's only the hospice providing the service that can approve that, correct?
Yes, so for general inpatient care, you have to make another set of qualifications for that. Not everybody that is hospice appropriate is general inpatient appropriate.
Right.
So with that, you would have to have that pain and symptom management where they are not able to provide that care in the home, or also if they are on any, per se, IV antibiotics that they're needing, that family does not have that support to be able to do that, we would contract with that facility. And once everything is resolved in terms of the pain and symptom management, or they finish those IV antibiotics, then we would transfer back home. And right here we have the hospice level of care. We have the percent of days by level of care. So we'll go with 2020, 98.7% of the patients that received hospice services were routine home care. 1% we have that general inpatient care. 0.2% we have the inpatient respite care. And then also 0.2% we have that continuous in-home care. But for the most part, the majority have that routine hospice care.
Question, just
Yes.
a point of clarification again. The routine hospice care, you do have to have a caregiver at home. Hospice doesn't do everything.
Correct. The majority, when it comes to hospice, the majority of the caregiving does come from the family. All right, and then this is our hospice interdisciplinary team. So along with the patient and their family, we have volunteers, physicians, spiritual counselors, social workers, bereavement counselors, hospice aides, therapists, and nurses. So our physician services that we have is we have an attending a primary physician that can be your PCP that would like to follow. We also have our hospice medical director, and they're responsible for the palliation and management of the terminal illness and conditions related to the terminal illness. So any medication changes that we need, say we're seeing a little bit of increased falls, or the patient's medication is not working, where they might need a change in dosage, we contact our medical director or the primary care provider of the patient and get those medications adjusted, and that usually is within that same day.
The hospice medical director, how often or do they come out and see the patient? Is there any requirement that they see the patient?
For the most part, the medical director does not come out to see the patient. That would be our nurse practitioners. Our medical director, we have weekly interdisciplinary team rounding where our medical director does come out to our office and sees every patient, what's been happening, what's been going on, and any medication changes that have been happening, how they are doing, and then adjust accordingly. Then we also have our nursing services. They provide direct patient care, responsible for the coordination and oversight of all patient care and services, provide guidance and support to patients and their families, inform patients' physicians of all the changes in condition, and also provide education on prescribed treatments, medication, and end-of-life care. We also have our hospice aides. What they do is they assist and provide personal care, including bathing, grooming, personal hygiene, toileting and incontinence care, positioning and transferring, and they help to provide emotional support for the patient and their family. Then we have our social workers as well. They assist families in navigating end-of-life planning, identify available community resources to help improve quality of life, assist and provide education on advanced directives, assist with faculty placement, transition planning, provide counseling to patients and families. We also have our spiritual care coordinators. They address the spiritual needs of patients and families, work with other professional clergy staff to resolve spiritual pastoral care concerns, work alongside bereavement coordinator to assist with grief counseling, assist patient and family with end-of-life planning. And these spiritual care coordinators, along with our social workers, once a patient has passed, which in TIVA, we do offer a 13-week bereavement. So after the patient has passed, the hospice services do not just say leave. What we do is we do provide a 13-week bereavement for the family's loved ones.
And what does that include? What does that look like?
So that is our spiritual care counselors and our social workers. So they have their own, each hospice is different. They have their own programs set in place where they contact the family as frequent as they need. They have that on-call support. So if a family is going through it at that time, it's a call to them and then they help with them. And then they also have services for support groups, sorry about that. I'm trying to go through all that. Support groups, grievances groups, things like that.
And do all the hospices do 13 weeks or different numbers of amount of time?
Different numbers. Some of the hospices that I know offer 12 weeks. We like to give that one extra week of support. Yeah, the majority will be 12 weeks though. Okay, and then we have our bereavement coordinators. They provide bereavement services for up to 13 months following the loved one's death, coordinate and facilitate all group support programs and bereavement services, conduct bereavement assessments to help determine appropriate services. So everything we just kind of talked about.
13 months, not 13 weeks.
Oh, sorry about that. 13 months, yes.
Okay.
13 months, sorry about that. So it is 13 months, not 13 weeks, sorry about that. Okay, and then we have our volunteers. They provide patient support and companionship, assist with household chores and errands, provide an additional link from the patient and family to the rest of the hospice team.
And how does that get set up?
So that gets set up with I'll explain. With Gentiva, we have a great number of volunteers, luckily here in Green Valley. We have about 21 volunteers. So how that gets set up is the patient or family would reach out to either the nurse, the aide, or the social worker, let them know that they're needing assistance. So per se, a caregiver is needing to run errands where they need to go to the store or they need somebody to stay with the patient. What they do is they help coordinate that with the volunteer coordinator depending on their schedule. And they come in agreement on a date and time where the volunteer coordinator, the volunteer is able to come out to the home and do so. Okay, and some additional services that we have. We do have occupational, physical, and speech therapy. So for occupational therapy, evaluate the needs of patient and their occupational role. Accessibility to dress, bathe, shower, assist with keeping optimal function mobility. Our physical therapy is provide straining therapy, and then educate on balance and fall prevention, training, transfer training. We have speech therapy, which is providing consultation in the areas of communication, cognition, and swallowing function to support the patient's role in decision making. So with these additional services, it's not going to be per se a home health, occupational, physical therapy, and speech therapy where we're looking towards the curative portion of it, where we're trying to get better. Say a patient had a fall, had a broken hip, and we want to try to get them back to walking and up and going as they were before they had that fall. With hospice, it's not necessarily the curative treatment that we're aiming for. So right here, like we said, we're going to focus on straightening. So say a patient did have that fall, was not a candidate for surgery, ended up going home with hospice. What we'll do is help with the mobility from transferring from bed to say the chair or wheelchair, things like that. So not necessarily the curative portion to get them back to their baseline, but just a little support to have that better quality of life. And then these are some of the commonly ordered hospice medical equipment supplies. These are all covered by hospice. It's a hospital bed, oxygen, wheelchairs, geriatric recliners, bedside commodes, shower chairs, transfer lifts, nebulizer, briefs, underpads, gloves, wound care items, and then other essentials to provide proper care. So say if somebody has a wound, we would provide the wound care supplies as well, things like that.
What's a geriatric recliner?
Geriatric recliner, have you seen in the hospitals, maybe here at Northwest, where it's the big recliner that kind of sets you back a little bit? It's just a hospital grade recliner, in fancy words. It's a chair. There we go. All right, and then these are some covered medications in hospice. It's medications related to the terminal diagnosis, medications used to treat pain for symptom management, medications that manage or palliate a related condition. Those are covered by hospice. And then who pays for hospice? Like we said earlier, it is Medicare, Medicaid, which is the Axis, private insurances, private HMOs, managed care organizations, and then we do have the private pay or self-pay option as well. A lot of people ask why hospice. This is patient-centered holistic care. Comfort is the priority. Home-based care, team-based care approach, family inclusive, and then focuses on the quality of life.
Jose, can I just back up to the medications
Yes.
for a second? So is it true that when a person goes on hospice, any medications that had to do with curative stuff get stopped?
Yes, so that is depending on the diagnosis as well that we admit the patient under. So with that, say a patient is diabetic and then comes on for kidney failure, we would not cover the insulin. That would still be covered by you. Any medications though that are on that are curative, our nurses come out and does what's called a medication reconciliation. So they will go through all the medications that a patient is on. And a lot of times we do see that some of these patients have multiple specialists where they're on 10 or 15 different medications that are counteracting with each other. So with that, our nurses do that medication reconciliation to where they see what medications can be taken away, and then any curative medication that the patient is taking that they are admitted under that qualifying diagnosis, those would be removed as well.
But do do they have the option to keep taking them if they pay for them themselves?
If they pay for them themselves, I believe so. Mhm. It just would not be covered under hospice. Mhm. Okay, and in summary, hospice focuses on comfort care, not curative care, requires an expected prognosis of 6 months or less for illness to run its normal course. Hospice is provided any place the patient calls home, covered under Medicare, Medicaid, private insurance, HMOs, MCOs, and then care is individualized and provided by the hospice interdisciplinary team.
Okay, this is a bizarre question.
Go ahead.
You said any place the patient calls home. Are you helping homeless people with hospice?
Any patient any place a patient calls home. We have had some patients that are homeless. So what we do in the sense of that, there is a program out there that's the Altex, Arizona Long-Term Care. We have our social workers, or say they're in a hospital with hospital social workers, try to get them on that program. And with that program, if they are placed on that, they help facilitate an assisted living for them, where we can then provide services. Mhm.
Is there a difference in the type or quality of care or services depending on whether you have Medicare or private pay or insurance pay?
Okay, so you asked if there's a difference in the quality of care in hospice with different payer sources? No, there is no difference. It's all you're going to receive the same level of care as if you were to have Medicaid or Access insurance. So you have access to the same level of care. The social worker, nurse, aide, medical director, medications, as well as medical equipment. All that is covered, whether you have Medicaid, Medicare, or private insurance.
And then, a second question, if you started with one hospice provider and then for any reason became dissatisfied, can you switch? Or when you sign that, what did you call it?
Authorization.
The hospice election.
Yes, when you sign that, does that mean you're committed to that, or can you make a change?
Okay, you asked if you're on service with the current hospice and you're having some trouble, can you transfer to another hospice? Yes, you can. So we have had patients where they start with one hospice, maybe they weren't receiving the care that they were promised. With that, you do have the right to elect a different hospice. And with that, what that is you would let your nurse, social worker know that you would like to change services after contacting the hospice that you choose to go with. What they would do is request the transfer records. You would stop services with that hospice company, and then they would send a nurse to do an evaluation and then start services with that new company.
Okay, thank you.
And there is no set number of times that you can do that. Go ahead.
You said you have people that come in to help with dressing and bathing. Are those certified nurse assistants, or are they trained in your facility? Or?
Okay, you asked for the caregivers that come out to help with bathing. Are they certified nurse assistants? Yes, they are. Yep, they are CNAs.
Do you have an addendum to this list of providers? This says most of these people are out of Tucson. There are some local companies, aren't there, like Bayada?
Okay, you asked, go ahead.
Okay, so there's one Green Valley company that's listed there, but all of these are the administrative locations of the hospital. The providers are scattered through community. The CNAs, the nurses and the like are scattered through communities. So it's something to consider as you're looking, the availability and the number of people available in the area. But everyone listed there is capable of providing complete hospice service in Green Valley.
Yeah, and you asked a great question that some of those agencies are located in Tucson, that is their administrative office. So with those hospices that are based out of Tucson, they do have nurses, caregivers, social workers that are within the area, so that way they can provide that care there and have that fast response time. That goes for everybody.
Okay, the experience I had with my hospice person, they work during the week, but on the weekend, you're on your own. You can call them if you have a problem, and they gave me a bag of medicine with my weekend. Is that really a common practice?
So you asked that one of your loved ones that you had on service with hospice, that they only work during the week and not on weekends. Okay, so that's going to change by agency to agency, depending on how they function. So I know with Gentiva, we do have that 24-hour care that if the need be on the weekend, you can give a call and we're there 24/7. With that, it's just based on agency to agency. With us, if we know that the patient really does have the need, we can have those scheduled visits for a Saturday or Sunday, and not necessarily saying, you're off on your own for the weekend. If the need is there, what the hospice agency should be doing is having those scheduled visits. Mhm. Yes.
As a practical matter, I think we're experiencing here and everywhere, I guess, just a shortage of medical professionals, whether it's doctors, nurses, aides, et cetera. How is that working out in the world of hospice in terms of ability to actually have the people that you need to do what needs to be done? Are you facing the same problem?
Okay, so your question is, you've been seeing staffing issues, and that's whether it's physician, nurses, aides. Yes, so a lot of the hospice agencies have run into some of those same issues. I know here in Green Valley, a lot of the primary care providers have left, so it does make it a little more difficult. But in doing that, with the hospice agency, as long as they're on top of trying to hire nurses, be proactive with that, then there shouldn't be that shortage where they're not able to provide the care that they need. And again, that's just dependent on agency.
How about volunteers? How are you doing with regard to being able to get volunteers?
So with here, I can only speak on my experience here at Gentiva. With Gentiva, we actually have 22 volunteers for the Green Valley area, and some of the other hospices that I have been in, I have seen anywhere from 2 to 5. So it's dependent on the agency. But for the most part, here with Gentiva, this is the most volunteers that I've seen, and they have a great relationship in the community. Any other questions? Okay. Oh, go ahead.
I'm still a little confused between the difference between palliative care and the hospice care, and yet it comes under the same. So when would I know to have palliative care instead of hospice?
Okay, so you asked what is the difference between the palliative care and hospice care? A great way that I like to explain. Good, okay. The best way that I like to explain the difference between palliative care and hospice care, with palliative care, you are able to still seek curative treatment. And with palliative care, you don't receive all the services that you get with hospice, per se, the medication, the medical equipment. It might be a little tougher to get that since you still have to go through your primary care provider. And with palliative care, the majority of the time it's going to be a social worker giving you guys a call, either bi-weekly, monthly, dependent on what you choose. So with palliative care, you're very constricted on what services you actually do get. But with palliative care, you do have that support from those social workers that are calling you. Say you need help with transportation to a medical appointment, or you need a wheelchair, they can help facilitate that. With hospice care, you have all those services provided to you, which is the medication, the medical equipment, and then along with our nurses, aides. But with palliative care, you are still able to seek treatment.
So is the palliative care set up through your doctor?
Correct, yes.
Repeat that question, would you?
Oh, she asked if the palliative care is set up by the doctor, by the primary care provider, and yes, they will be setting that up. Any other questions? Okay. All right, thank you.
Thank you, Jose. So this concludes our session today. Our next presentation is on wills, trusts, and fiduciaries in 2 weeks. That's April 11th. At 11 o'clock, it's going to be in the Fellowship Hall, and there are sign-ups over here. Otherwise, we'll have sign-ups also starting on Sunday. And make sure you remember about the brochures in the back if you want to get any of those. And thanks for coming. I hope you come to the next one.
Perfect. Thank you.